about. It's actually a good assessment tool, because if people joke about my name, then I know that they're not as depressed or less severely depressed. And I've had people joke about my name and then forget that it was my name. So that's a good cognitive tool. And I've actually had somebody paranoid not actually believe it was my name. So there you go. This is a very vast topic, and I can't do justice to it in 20 minutes. So my goal is going to be just to give you a framework for understanding grief and bereavement while touching on key aspects of it. So nothing really to disclose, and no bias. And all right. So by the end of this talk, I hope to answer the following questions. What is normal grief? What are the complications of bereavement? And I also want to share a clinical approach to bereavement in older adults. And along the way, there's going to be opportunities for you to reflect on how the effect of the pandemic is affecting grief and mourning rituals. Grief is a response to significant loss. It's a universal experience, but its expression is going to vary depending on your culture. And for everybody, it's going to be also unique and personal. And every loss is also going to be different. And the feelings can be all over the map. So you hear people describe intense sadness, feeling empty, feeling numb, anger, denial, blame. So it's really a complex mix of emotions, and it can be overwhelming. And ruminations about the loss are also common, and insomnia and loss of appetite as well. And those are all features of normal grief. And what I'm saying comes right out of DSM-5, but I want to underscore that the intention is not to pathologize normal grief, but it's to outline its parameters so that it can be distinguished from problematic grief. And for that reason, I'm also not going to be calling it abnormal grief in my talk, because I always figure, how do you judge if somebody loses a child? You know, it's a devastating loss. And who's anybody to indicate what the time frame should be? So no judgment. In normal grief, thoughts about the deceased in normal grief, the ruminations are about the person that's died, while in depression, they tend to be self-critical. And in grief, a person may ruminate about things they could have or should have done to save the person. If only I had done this, so-and-so would still be alive. But they're not broadly self-critical. And the bereaved can also access often positive memories of the deceased, or the notion of laughing through your tears as you remember a funny story. And somebody that's grieving may actually also have thoughts about wanting to join the deceased, to be with them, but it's about yearning and longing rather than in depression wanting to die because they feel so worthless. So depression, self-critical and pessimistic, and that's one difference, again, right out of DSM-5. And self-esteem is preserved in grief, unlike in the self-loathing of depression. But this distinction between grief and depression is not always so clear-cut. So grief is a response to loss, and bereavement is among the worst loss that you can experience. But older adults are vulnerable to all sorts of losses, and not just the death of friends and family, but job loss, retirement, having to downsize and give up possessions, loss of health in oneself or one's spouse, including cognitive changes. All of this can also affect mobility and hearing and vision, and also loss of a license, loss of independence. And there's often an intersection of these losses that are not always named. And I'll talk about ambiguous loss in a moment or two. But also a point to make is that older adults are quite resilient in the face of loss. And that's the work of George Bonanno, who's added to this concept. Ken Doka coined the term disenfranchised grief, which captures grief that's not always well acknowledged or supported by society. And the term refers to examples like infertility or miscarriage, chronic illness. And I wonder if long haul COVID might be one such example, though the studies don't yet exist for that. And Pauline Boss, many of you have heard of, I believe, ambiguous loss. So she talks about loss where the person is physically absent, but psychologically present. And an example of that might be somebody that's missing or lost at sea. And more commonly, physically present and psychologically absent. So that would be somebody with dementia. If you consider that you have a loved one with dementia, you don't get necessarily an outpouring of support when they get moved to long-term care or when they don't recognize you anymore, but these are significant losses. What about anticipatory grief? It's a common topic, but not as much in the biomedical or scientific literature. And in fact, a systematic review of caregivers of terminally ill adults included 34 studies, so they were middle-aged. Anticipatory grief, that's the experiencing of grief-related distress before the loss even happens, may not in fact be such a good thing. And it turns out that caregivers that had more grief before the loss had worse bereavement outcomes. And COVID has meant a perfect storm of loss as well. So it's not just the illness, but for some it's loss of a job or how you work, whether it's in an office with lots of connections or at home alone. And if you were retired, not seeing friends and family, you know, not going to exercise class, not seeing your grandchildren. And if you've been bereaved during COVID, you may be cut off from your support network. The rituals are certainly different with restrictions in cemeteries. And I'm not sure how the mourning as a group, as a cohort is going to play out, but I'd be interested in your thoughts at the end about that, perhaps. Just how profound an impact COVID is going to have on bereavement outcomes is yet to be seen. That these researchers have developed a COVID-19 bereavement multiplier, which is an indicator that estimates the number of individuals who will experience the death of a close relative from each COVID death. And as of June 13th, I checked on that date, there were 600 deaths in the US. So that means that 5.4 million people will have experienced the death of a close relative. And by that, they meant a grandparent, a parent, a sibling, a spouse, or a child. And I want to talk now for a few moments about conceptual models for understanding grief. And I'll touch on each one briefly. In 1969, Elizabeth Kubler-Ross wrote about the 5 stages of grief. And this model was actually used to describe people that have been diagnosed with terminal illness. The thing is that grief doesn't necessarily follow a linear trajectory, and people go back and forth between these stages. She actually later expressed some regret that her description of the stages were interpreted as, I quote, a simple way to tuck messy emotions into neat packages. And in fact, research hasn't borne it out. And similarly, Warden writes about the 4 tasks of mourning, where grief is an active process where you have to accept the reality of the loss and work through the pain, process your grief and adjust to a world without the deceased person. But you have to find a way still to connect with the deceased. And keep this in mind as I go on to Tonkin's Growing Around Grief. And this conceptualization, here's a visual. Grief doesn't reduce so much as the life of the bereaved person grows around the grief. So that means things like new relationships, new friendships, travel. Those are all examples of growing around grief. Kathy Shear is the director for the Center of Complicated Grief at Columbia, and she's made considerable contributions to the field. And in fact, last week I had the opportunity to hear her speak at this education session rather. And she talked about losing a loved one as the most stressful thing that you can experience, but that its hallmark is a separation response. This is at the core of grief, where the yearning and longing that I mentioned before, it can also be a challenge to adapt to what feels sometimes like a nightmare, like you're in a different universe that you find yourself in. But those are the key aspects of it, and keep that in mind, because the other thing is that humans resist separation. And this is, by the way, John Bowlby, who wrote about how you look for proximity to your attachment figures. And early in grief, you might feel like your loved one's going to walk through the door and you can touch them. So it's especially if the loss is unexpected. It's the feeling of shock and disbelief and protest that are actually kind of defenses. But that needs to change, and the relationship has to get reconfigured over time. So the relationship continues, but it's changed. And once this acceptance occurs, the grief still remains, but it's something that's called permanent grief. So getting back to normal grief, acute grief is intense and painful, and the waves can be overwhelming, but over time the intensity wanes, and it takes on a different form, so that it'll always get triggered by anniversaries and holidays, and triggers that are bittersweet. And that's something that distinguishes grief from depression, which is fairly pervasive. And this model, the last model I want to mention, is that of the dual process model of coping, which really does speak to this notion of oscillations rather than a linear concept. So it depicts grieving as oscillating between two types of coping, where one is focused on the loss itself, the intrusive thoughts and the sadness, for example. But then it's also restoration-oriented coping, where new roles and relationships are created. It's kind of the life-affirming stuff that you have to keep in mind for your clinical interventions. So bottom line, adapting to bereavement is a back and forth dynamic process and not a linear one. And here's just a visual I found on the internet if you want to take a look at that for a sec. So now I'm going to introduce you though to Ms. Bereave. So she was recently widowed and she can't stop thinking about her husband, and she's having trouble concentrating. She feels sad and empty. And I could ask you, is this normal grief? I'm wondering if you might be thrown by the time frame of her loss. I mentioned it's last month. And what if he died, 5 months ago or a year ago? And I would say that this could very well be normal grief, but she could also be depressed. But now it is 5 months later, and she's been crying a lot, feeling pretty hopeless, and she's not enjoying herself. Her nights are terrible, and you get the idea. So what I want to tell you is that there's no time frame for depression, and it can be diagnosed at any point during the bereavement trajectory. And also to highlight that significant loss doesn't necessarily only mean bereavement. It can mean things like, as per DSM-5, financial ruin, disability, and or illness. And there's a danger in not addressing the clinical depression when it's present, even if it's understandable, and there's a reason, because we have to consider the negative health outcomes of untreated depression. So complications of bereavement is the second objective. Bereavement-related depression is the same as major depressive disorder in the context of bereavement, prolonged grief disorder, and there's a myriad of health outcomes that I'll touch upon. So bereavement-related depression is common. It's been recognized for more than 50 years in the bereavement literature. And I don't have time to get more granular about age and gender differences, but in the widowhood, these are the stats that you're looking at. And I can summarize this slide by saying bereavement-related depression and major depressive disorder are the same entities. And here we can treat the depression as you would treat any depression. And there aren't any studies that I'm aware of, though, for MBSR and problem-solving therapy specifically with bereavement. But depressive symptoms like loss of energy and motivation make it harder to really practice the restoration coping strategies that I was talking about, doing new things and strengthening relationships. That's why you want to treat the depression first, so you could tackle the grief. And depression can very much impede adaptation to loss and grief. It's 13 months later, and I'm checking my timer to see how I'm doing. Okay, very well, thank you. It's 13 months later now. And as an aside, in bereavement research, you don't follow people, you don't do follow-ups to 12 months. And I could ask you if we were in person to answer. The reason is the anniversary reaction. So I just chose 13 months later. But Ms. Bereave says that she can't stop thinking about her husband. She's suffering. It feels like he died yesterday. She can't believe he's gone. And she says, I can't look at his picture. It's too painful. My friends don't understand. And I feel empty. I'm angry at the doctor. It's her fault. My husband died. It's just not fair. So prolonged grief disorder is the entity formerly known as traumatic grief and complicated grief. And in essence, it's acute grief that never gets integrated. It's not different. It's just grief that doesn't fade or there's no adaptation that happens. I don't need to speak about PCVD, which is in DSM-5 as a condition of further study because nobody talks about it. But I can tell you that prolonged grief disorder is not that rare. And in fact, a recent cross-sectional study out of China found the prevalence of close to 40% of complicated grief, what it was formerly known as, in their sample of COVID bereaved. The good news is that the entity is going to be kind of aligned and harmonized in ICD-11 and DSM-5 TR. And it's often comorbid with depression, anxiety, and PTSD. There are provisional criteria for its disorder that have been accepted by the World Health Organization, and it's going to appear in the 11th iteration of the international classification. We'll just call it ICD-11, which is coming into effect in January 22. And following the death of a partner, a parent or child, or a person close to the bereaved, there's a persistent, pervasive grief response with longing or preoccupation, and the feelings are intense, and the responses last for at least 6 months, and it's out of keeping with cultural norms. And these are the draft criteria for prolonged grief disorder that will appear in the next iteration of DSM-5. And the only difference here is that it's more than 12 months after the loss. And the grief response has to have at least 3 of the following 8 symptoms. And disbelief, numbness, avoidance. And again, to reiterate, it's not a completely different way of grieving. It's normal grief that persists, and the adaptation to loss is somehow blocked. And you can get those online. They're easy to get. And Shira and her colleagues have outlined some of the core aspects of the treatment, where the goal is to facilitate acceptance and understand the grief, and then to regain the ability to experience positive emotions connected with the deceased person. And it's important to tell the story of the death and to help the individual, again, feel connected to the deceased. So there's a lot of psychoeducation and journaling that are used, and imaginal conversations with the deceased, as well as goal setting and identification of pleasant activities. There have been 3 randomized controlled trials that have been done. This is formally known as complicated grief treatment, and there's a manual. And you can get it online through the Center for Complicated Grief website. And the core components are exposure, like revisiting the death, but also cognitive restructuring. It's also appears to be twice as effective compared to IPT, and it's been studied in older adults as well. And adding citalopram, of note, does not improve complicated grief or PGD, but it does help depressive symptoms. So we've talked about the first 2 complications, and the bereavement-related depression and prolonged grief disorder themselves lead to adverse health outcomes, including suicide, but these are all reported just in the general course of bereavement at increased prevalence. And pre-existing conditions tend to become worse, sleep disorders, PTSD, and yeah, so let's focus on those. So this is another outcome that's been borne out by very large prospective studies of large populations, and it's especially increased during the first 3 months of widowhood. And Parks and colleagues, they wrote about this in the 1960s, the broken heart syndrome. And another large prospective study looked at a mortality among bereaved older adults, especially in the early days after loss. The risk falls after 90 days, but there's some real physiological things that happen that increase the risk of myocardial infarcts with changes in platelets and heart rate variability. I can mention this briefly, Takotsubo cardiomyopathy, which is described in bereavement, and acute stress can cause the left ventricle to balloon out and dilate and cause shortness of breath and pain. It tends to resolve though within about a month. So there are many negative health outcomes associated with bereavement, and increased systemic inflammation and lower antibody responses compared to non-bereaved, increased cancer rates, more medication and over-the-counter and benzodiazepines. Cognitive functioning is affected with slower information processing speed and verbal fluency in studies of older adults, and unmasking of cognitive issues. I see that where somebody dies and it turns out in the surviving spouse, the person that died was actually covering up a lot. So that's something to keep in mind. And finally, treatment. It says, hard to tell from here, could be buzzards, could be grief counselors descending. So there are assessment tools that elicit symptoms of grief, like the 5-item self-report grief questionnaire, which asks questions also about avoidance. And again, very small fee, I think it's like $4 on the website, you can get it. And I'm not going to go through these all in detail, but these are some of the things. I don't typically use them, but the lost sum looks at who's died and how that's affected you. And the difficult times questionnaire looks at anniversaries and difficult calendar dates. And I want to give a nod also to Holly Pridgerson, who's also done a whole lot of work in the area and came up with the prolonged grief disorder revised scale, and before that, the inventory of complicated grief. So clinical approach, I think that it's exceptionally important to get details of the circumstances of the loss while thinking of what is going to make this person vulnerable to all the outcomes that I just mentioned. Who's vulnerable to the adverse outcomes? And I've bolded examples where these are risk factors for prolonged grief, but these are just general risk factors that encompass difficult courses in bereavement. And was the death unexpected? Keeping in mind that, again, even somebody that's terminally ill can die unexpectedly. It could be perceived as unexpected. But certainly murder and suicide, not feeling prepared, multiple losses at the same time, having a close and even dependent intertwined relationship with the deceased. It doesn't mean that if you have a conflictual relationship, you're not going to have a difficult thing, but these are risk factors identified in the literature. And loss of a child, caregiver burden, especially when the loved one dies with uncontrolled pain and it was a difficult death. But especially early, when people say I'm doing okay, that's the best thing I can hear, because people that have early guilt and anger and distress, they're very, very vulnerable to adverse outcomes. And certainly getting a history of what their past is like is important as well. Spiritual beliefs, traumatic loss can precipitate a spiritual crisis even, but I don't have time to go into that. So really important to consider routines and good nutrition, sleep hygiene and exercise, and that's from studies of older adults. It applies to younger adults. And just to wrap up, you have to recognize who might be vulnerable in the aftermath of loss. The knowledge of the models of grief teaches you things about restoration-oriented coping. Listening to the story without judgment, because you can't apply your own experiences to their loss. And sometimes it's hard when you're sitting with somebody that's grieving intensely the loss of their 95-year-old mother in their sleep, and you've had significant loss yourself. Again, it's not what you say, but how you listen. Very important. And it's permission to grieve in one's own way. Educate people about anniversary reactions, the importance of rituals, and just consider the impact of COVID on mourning rituals. I don't have answers for you. I can just say that it's a big issue. Journaling can help, and resources like poetry and literature. And I've included some here that we can share in the resource, but that can be quite helpful. I haven't read the last article, but Kathy Shear mentioned it in the talk last week, and she seemed to really like it. So I've included it here. And Strobe's Poetry of Grief really gives you the key highlights of poetry. And I have some additional references that really apply to the clinical approach slides. I couldn't fit it all in. And I just I'm gonna leave it here. Here's some links that I find useful that I hope you will as well. And I think that's it.